My name is Dr. Arshad Iqbal. Today I will talk about how to treat a patient with lower respiratory tract infection. When a patient comes with symptoms of fever, cough, breathlessness, chest pain, we must differentiate whether these causes are coming from the chest or from the heart. We should auscultate the chest, see the status of the respiratory system. Then we should do ultrasound scan. Thoracic sonography is done along with abdominal ultrasound and echocardiography of the heart. In thoracic sonography, we will see comatal artifact, A lines, B lines, any focal mass, and in abdominal ultrasound we will see for pleural effusion and status of the liver, kidneys, to rule out the causes for cough, breathlessness, chest pain. And on echocardiography we will, along with subcostal view, we will see for the heart, movement of the interventricular septum, left ventricle wall, right ventricle wall, status of the mitral wall, status of the aortic root, aortic wall, left atrium diameter, right atrial diameter, left ventricular diameter, coronary status, E-A curve, endpoint septal separation, ejection fraction. Ejection fraction in echocardiography is very important in this case. Then we can have an X-ray of the chest to rule out what may be the cause. Causes are bacterial. If it is lying in the chest respiratory system, may be an infection by bacteria, virus, fungi, or any mass in the respiratory passages, which is very, very important to see, to rule out a mass in the respiratory passages. Chronic long-standing breathlessness is very important. Then we rule out for cardiac causes. In cardiac asthma, in the heart is dilated. There may be hypokinesia of the IVS, hypokinesia of the left ventricular wall, and normal and diastolic diameter of the left ventricle is up till 56 millimeter. If it is more than 56 millimeter, then the cause is lying in the coronary arteries. We will do C for myocarditis. In myocarditis, on the mitral wall, the vegetations, echogenic structures are seen on the mitral valve or tricuspid valve or on the pulmonary valves. We will see the pulmonary artery, pulmonary arterial pressure. We will see the diameter of the left atrium, which should not exceed from 40 millimeter of mercury. 40 millimeter in diameter, and the pressure of the pulmonary artery should not exceed 25 millimeter of mercury. Now, if the cause is lying in the respiratory system, you have ruled out the cardiac causes, then the treatment is good quality antibiotics, in which Moxifloxacin, ciprofloxacin is a drug of choice. If someone is allergic to this, we can select the appropriate antibiotics for this. Bronchodilators if there is asthma, and expectorants, and if there is a cardiac cause for the cardiac asthma, for the chest pain, then we will rule out hypertension, we will give antihypertensive, we will give statins. Nowadays rivaroxaban is also very good. We will give clopidogrel, we will give dispirine, we will give coronary vasodilators, and we will give bronchodilator also. One should be very careful in chest infection while lowering the blood pressure. The beta blockers are not recommended. We will rule out the bradycardia also. Beta blockers are not recommended. The management of lower respiratory tract infection is easy. First, we have to see the cause. Either it is a cardiac or it is coming from the respiratory system. If there is a pleural effusion, we will drain it. If it is tubercular, then we will give anti-tubercular therapy for 6 to 9 months. Sometimes in myocardial infarction, the mitral valve is highly destroyed. There is atrial fibrillation, ventricular fibrillation, there is tricuspid regurgitation, there is mitral regurgitation. Due to mitral regurgitation, there is lot of congestion in the lungs. The lungs becomes opaque. On X-ray, there is white, big opacity seen. Lung is collapsed, and that's a very critical situation. The patient's survival rate is grossly reduced. My name is Dr. Arshad Iqbal, Arshad Ultrasound Clinic, Salim Arcade, Q Block, Model Town, Lahore. Thank you.